Hello, my name is Mark Revenaugh. I'm a veterinarian in Portland, Oregon. I am happy to be here. I think we have a few minutes to talk about what was requested to be two interesting lameness cases that maybe started off looking like they were going to be one problem and ended up being something a little bit different than what we expected. So if you're interested and willing, here we go. First case is a horse named Dante. He's a 14-year-old warm blood gelding who is doing 4th level dressage. As of about 2 years ago, he started to develop a low-grade left hind leg lameness. His history is kind of interesting. He has had an ongoing variable lameness, meaning that some days it's better and some days it's worse. Again, I'll say this started 2 years prior. It was mild and there was no known history of trauma. The horse didn't get kicked. He didn't have a real, especially hard work session or anything like that, but he started developing these symptoms. So the initial therapy from the referring veterinarian was to inject the low Hock joint with steroid. I think probably most owners are familiar with that. It's a very common therapy that we do. It's one of the more common sore areas. What I would bring out to your attention here, maybe the first thing I should have pointed out is that the horse is a very difficult patient. When I say that, I mean he didn't want you to pick up his hind leg. He would try to kick at you. Although he's a good-natured horse, he made it very, very difficult to assess him. About anything that you squeezed or poked at on his leg, he thought he didn't like that and he would try to get you. So he did not help the initial veterinarian, and when he eventually got to us, that was also the case. It made it very difficult to help him. But anyway, after the Hock injection, the owner reported some partial improvement, certainly never resolved the problem, but they thought it helped. They brought the horse back into competition, back up at 4th level dressage with some level of success. These are the initial radiographs, just 2 views that I brought up. You can see there's mild arthritis in the low joints of the Hock here. And do I have a pointer? Yeah, I do. Okay, so these are the joints that are typically involved with low joint arthritis, and they look pretty good here. It's not uncommon for a horse to have low Hock pain without radiographic changes. I don't think that the referring veterinarian was wrong to give the low Hock joints an injection. But then 18 months later, after a hard work session, the lameness seemed to deteriorate. The client also noted that it seemed like it was the same problem, same kind of characteristic gait problem. However, it was just much more severe. So then the owner decided to bring the horse to university for some further diagnostic tests. From their records, the horse was grade 3/5 lame. That's a pretty salient lameness. He's able to bear weight on it, but it's pretty obvious that he's lame. They did nerve blocks, which was probably an exercise in taking their life into their hands, knowing this horse, but they blocked the foot, so they anesthetized the foot so the horse didn't feel his foot. That did not change the lameness. They did a low 4-point, which is then everything kind of at and below the fetlock joint, which did not help. They infiltrated Novocaine into the suspensory ligament at its origin, and that also made no impact on the horse. Finally, they blocked the stifle joint, and they said that in their records that there was no change whatsoever. So this leads us in our quest to figure out where the problem is. This leads us toward the Hock joint or above the stifle joint. These are the radiographs that were then taken in this last August at the university, and you see that there is a little bit more arthritis here in these low joints, but still certainly by no means anything very remarkable. They injected all 3 joints with steroid of the Hock, and this time the owner noted that there was very minimal response to therapy. So they then came to us. When we saw the horse, he was grade 3 lame, so again, pretty darn lame. He appeared to be resentful of middle leg flexion, although he was kind of resentful of everything. We noted some swelling at the point of his hock, although he was quite fuzzy, so it was hard to really get very specific about that, but we noted that on his exam. And again, I'll reiterate, he was difficult to assess. So the owner had requested, well, the owner discussed with us what our options were, and we suggested that you do a bone scan on the horse and see if there's something higher up or something more exciting going on that we're not picking up. So I only included the one image that was relevant here, and this is looking at the hocks from behind. You can see, if you see my arrow, there's a bit of uptake on the point of the hock, but it really isn't a very exciting bone scan uptake. The rest of the leg looked quite normal, the pelvis looked quite normal. This is the only thing that lit up at all on the bone scan, so I suggested taking a few additional radiographs that maybe were not taken initially, and because the lower hock joints did not appear to be very active, that made it much less likely that that was the problem area. So we took some radiographs, and we did indeed get some interesting findings. These are not normal findings. On this view, you're looking at the hock from behind, and you can see quite a bit of lysis or demineralization of the bone along in this area. I would tell the viewers this is not an area that we routinely scrutinize on. And then when you do what's called a flexed skyline view, so we're flexing the hock and we're looking at this bone here from the top looking down, you can see that there's clearly a bone injury on the point of the hock. So at that point then we decided we should probably look with an ultrasound machine to see if there's any soft tissue component to this. And as we prepared the horse, he was quite fuzzy, had long hair coat. When we clipped him, we actually noticed that there was a lot more swelling, specific swelling and non-specific swelling around the point of the hock than we had realized. I included a video I hope will demonstrate what actually happens when we watch the horse walk once he was clipped. Is this tendon here, this is the horse's Achilles tendon, but the specific part of the Achilles tendon or the gastroc tendon that we're worried about here is the superficial flexor tendon. As it comes down, it becomes kind of flattened across here, and then it continues down here to what we all know and are familiar with as a superficial digital flexor tendon. But what happens, you'll see in the video, is that as the horse walks, this tendon slips back and forth. It doesn't fully slip all the way over to the side, but it's a partial subluxation. So let's see if we can find it on the video here. Yeah, it's kind of hard to see here. Let me play it one more time. Yeah. Anyway, maybe it's a little easier to see real time, but that SDF is just so slightly slipping back and forth as the horse walks. When we ultrasounded the horse, you can actually see on the right-hand side is the outside. This is the bone surface, which is quite normal on the outside, or the lateral aspect of the point of the hock. And then this structure, all of this right in here, is that superficial flexor tendon. As we wrap around to the inside, you can see a very abnormal bone surface right in here where that superficial flexor tendon should be attaching, right? So this is actually a partial luxation and a tendinitis of this superficial flexor tendon here on the medial aspect. So that's our actual diagnosis. I would tell you it's a very abnormal and very uncommon finding. A more common version of it is when the tendon actually slips all the way off the point of the hock, and then it's very, very obvious. Unfortunately, that problem has a poor prognosis. Here's just some anatomical specimens, so maybe you can appreciate it a little bit better here. This is just the bone itself, and you can see the point of the hock on the inside and the outside. This is right where that superficial flexor tendon kind of reaches down around and attaches onto the point of the hock, so it won't slip inside, it won't slip outside. And you can see here, this is the superficial flexor. This is where it wraps down and attaches. And this is where it then continues down. Yeah, so a little anatomy lesson there. And again, this whole thing is your hock, and this is the point of your hock here. So I wanted to bring up a couple interesting points regarding this case. And one is that the horse did appear to get some response to a steroid injection of the joints. So that could be either because there was some pain in the hock, so another problem happening at the same time, which is possible. The other possibility is that just giving steroid into a horse's leg, into his joint, will give you a regional anti-inflammatory effect, kind of a non-specific anti-inflammatory effect. And I've certainly seen that in a number of cases. Typically, if you treat a fetlock joint, you might make a soft tissue structure around the fetlock joint feel more comfortable, maybe reduce some swelling, something along those lines. And it can be deceiving. You know, you treat a joint and it gets better, you think, well, boy, there's our diagnosis, I got it. But that doesn't always happen. A lot of times what happens is you get a kind of a transient improvement, and then as soon as the steroid wears off, you're right back to where you were, or sometimes even worse. The other point I'd bring up here is that sometimes the patients make my job difficult. We veterinarians aren't able to interview our patients, and so we rely a lot on palpation and just feeling what the horse feels like when you poke and prod and flex and what have you. And a horse like this, he's a good horse, don't get me wrong, but he really made that part of it difficult. It's quite possible that if he had been more quiet for us, that we could have picked this type thing up on palpation a long time ago. But as I said, almost everything that you squeezed and poked on with this horse, he resented. So it really made it difficult to assign an awful lot of significance to it. And the last thing I would just bring up is that not all, this area was localized, well, it was by exclusion localized to the hock. It doesn't mean that he just has low hock joint arthritis. I think that's a very, very common misconception. A lot of clients would bring a horse like this to us and say, well, we think the horse's hock is fusing. What can we do to fuse the hock so that the horse becomes sound? And of course, in this situation, it would have done nothing to help the horse. So I think that's the end of the first case. The second case is a different type story. It's a 11-year-old thoroughbred gelding. This is an advanced level of gelding, so he's a real athletic fellow. He's done his job for many years, but he was competing last summer at the advanced level, and he became acutely non-weight-bearing lame out on the course, on the cross-country course. So they discontinued. They didn't use an ambulance, but they were able to get the horse back to the stall. There was a lot of concern. I'll get into some more details in a second, but the horse was presented to me 2.5 months later, 2 months later, and he looked pretty good, and they wanted to know, is he safe to bring back into work? They wanted to get him conditioned again so he could go out and do great things out in the field. So at the time of the injury, when they brought him in off the course, we talked with a veterinarian who was there at the show, and he said, boy, his legs were tight, cold, nothing on him. The only thing, hoof testers were negative. You got to worry about a horse like that maybe broke his coffin bone or something along those lines, stepping on a rock out on course. But the physical exam at the time was reportedly pretty non-remarkable, except that any flexion on the leg of concern really made the horse uncomfortable. And secondly, when they tried to pick up the opposite leg, he did not want to bear full weight on the affected leg. At the time, they took radiographs of the horse all over basically up and down the leg. The referring vet at the time was concerned about a fracture, a hairline fracture, but they were not able to confirm it on any of their views. This is just a radiograph of the stifle, which looks quite normal at the time. So he came to our clinic about 2 months later, and I watched him. He was maybe a grade 1 lame, so difficult to see, minimal lameness. I went up and down the horse's leg at length, palpating, flexing, trying to elicit some kind of a pain response. When I hear of a horse that becomes as lame as this horse was, I'm really concerned that there was a big injury, right? The degree of lameness that they described, and for it to come on as acutely as it did on course, really is concerning to me. So I'm looking at this horse in front of me in the clinic who looks pretty good a couple months later. They want to go back and do really, really hard work on the horse. I had to have a long conversation with the client, and this was a situation where what I saw in front of me looked pretty good. But my intuition told me that there was something more going on here, and the client wanted to know what to do. So I think in this situation we actually had one conversation, and she was going to bring the horse back into work, and I went on and worked on another case, and then I came back to her and I was shaking my head and I said, you know, we need to look harder. This thing bugs me. I don't know what it is. I hope I'm wrong, but I think there's something more going on here. So we had conversations about what to do. Certainly, you can do repeat radiographs, but a horse like this, I don't know where to radiograph. I can ultrasound. I don't know where to ultrasound. There's nothing on the horse's physical examination. So I don't bone scan all the horses I look at, I swear, but these are interesting cases. And so here's some bone scan images of this horse. You can see trigger on his right front, his right stifle, his right hind. There's some increased uptake here. So this is some inflamed bone down on his tibial crest, right below his stifle joint. I would say that this is not a real remarkable amount of uptake. I would say maybe moderate uptake. And we see uptake along this line sometimes in horses that are working real hard. We then had a similar conversation again about what do we want to do? Do we continue to pursue it or not? And I had suggested that we should probably at a very minimum take some radiographs of the horse's stifle just to make sure we're not missing something. At this point, I'm really thinking there's probably not anything real big going on here. But when we take the radiographs, you can see the normal one here. This is his tibial crest. And on his abnormal one, he has a hairline, well, a partially displaced fracture right along in here. And then when we do ultrasound examination, we see that he has a badly injured lateral patellar ligament, outside patellar ligament here. Not a real common injury that we see. Not a real good injury to have, almost always associated with direct trauma. And this horse must have hit a fence hard. Event horses frequently will hit their stifles as they drop down and land below where they took off. As they go over on the 3-day course, the fences don't move. They're frequently railroad ties or I should say telephone poles or really big pieces of something very solid, so they hit them and they can traumatize that area. He ended up getting stall rest and shockwave therapy on the area. I think we would have talked more seriously about surgical options, and maybe we still will, about stabilizing the area surgically. However, with the horse showing such minimal signs, we have to consider that the necessity of doing that and taking on the risks of surgery, whether they're warranted or not. So this is kind of a scary case to me. This would have been very, very easy as the veterinarian to say, hey, look, the horse is minimally lame. You should be, cursory examination was very non-remarkable. This would have been a very easy case to say, okay, go ahead and work your horse and let me know how it goes. So fortunately, we did pursue it and found an answer and prevented what probably would have progressed quite substantially had the horse returned to work earlier. The flip side of this, the reason I bring this up, the reason I think this is an interesting case, is that sometimes you pursue these things in this situation and there's nothing there. And it's difficult as the veterinarian to try to give good advice. We don't like to just pursue things that don't need pursued, but we also don't want to miss something that's really, really important. And to me, I rely a lot on the history of the horse. That's really probably what's steered me toward pursuing this thing more than anything. And interacting with the client. I think it's really important to discuss this pros and cons, the types of things that you're worried about, and coming up with a decision as far as what to do as a team. And because there's not always a real clear-cut right and wrong answer. Sometimes it's really beneficial to a client to pursue it and find out that there really is nothing. The client can sleep better, and there's a lot of value in that at times also. But in this situation, it would have been very, very easy to skip any additional diagnostic tests. So I think that's the end of the talk. I'd like to thank everyone for their attention. Hopefully we learned something, and I would emphasize that these are not typical cases. So there's nothing wrong if you need to. Horses frequently get low hock joint arthritis and respond very well to hock injections. I'm not trying to dismiss that fact at all. But regarding that, when we find that our therapies are not doing what we think they should, usually there's something else going on. And the second thing I would say is that I think taking the time to listen to the client and getting a good history, discussing with them what we think is going on or what might not be going on, will help us in deciding what type of diagnostic tests or therapeutic tests are appropriate. So with that, thank you very much and have a good day.